some structural abnormalities in the brain. Some, they can be a metabolic abnormality, sometimes can be infectious, sometimes it can be a genetic predisposition, and there is a lot of work that's being done right now to try to identify all the genes, and we do not know them. And we go through this list as we're trying in our minds to figure out what's wrong with the patient. But we also have, with the person, but we also have syndromes. And syndromes are a constellation of symptoms and signs that we put together, and we try to prognosticate what's going to happen as the person gets older. And some of them come from the experience of sharing with a lot of patients, and we'll try to put that much information down. But there is this syndrome that's called generalized tonic-clonic seizures. Initially it was upon arousal, but now we change the A to alone, that you don't have any other seizure types. And they don't happen very often. Sleep deprivation can be a problem. The medication, the best medication, unfortunately, some of them will go away after a certain, but the best medication that works for this condition is a medication that, come on pharmacists. Generalized tonic-clonic seizures upon arousal or upon awakening. It's a medication that works very well, but there is a but into it. So that should give you a hint. Valproate. And this is a medication that was discovered in an amazing way. They did a drug trial. There's a lot of companies here that try to make drug trials. And they took a group that they had the solvent, and they gave that as a placebo to the animals that they were testing it. And then they put that solvent and the medicine together. And the other animals got that. And to their surprise, they found that the animals without the drug did better. And that was valproate. And valproate is a terrific medication, but it has some problems that we have not figured out yet. And if you give it in a dose that's more than 750 milligrams a day, it can cause teratogenicity and autistic features in the babies. So that's what we're afraid to give it to women of childbearing years. But sometimes the seizures, if they have not been controlled with other medications, sometimes valproate in doses less, 500 or less, can control the seizures. And with 500 milligrams, we do not develop the teratogenicity. So it may be worthwhile to talk to your doctors to see what medications.
I do have a question.
Okay? Should. What? Yeah, Lamictal is a good medication. I will say everything that's good. Yes, okay.
I keep right.
All right. It doesn't say how much of which.
She takes 350 and 200.
So all of it is working with the drugs. I'll give you a very nasty secret, okay? It's very nasty. How many of you do you cook? You like to cook? Do you like to cook by following the recipe, or you change it around?
I do change it around.
You need to change it. So that's the same thing is with anti-seizure medications. You have to figure out how they work together, and you have to try, and as long as there are no side effects, then you keep on pushing the medication, and you hope that you have some success. And what I would recommend is talking to your doctor to see the reasons why she's taking those 2 medications besides being the most recent medications that they've come to be available. And other medications can be tried, which may have less side effects than. As a general rule, also, they tell you a lot to be concerned about the levels of how much blood you have in your system, right? They tell you that. But when the drug comes out, we don't know that. And they tell you, oh, you can take that drug because you don't have to measure the levels every time. And then they measure the level and they say you have to be in that therapeutic range. There is no therapeutic range. You have to push till you get any side effects. And then you know you have enough. Okay, any kind of side effects. It may be that you don't like my nose. That's a side effect. All right? So that's the way I would like this hour to be. You can ask any question and we're trying to come to an answer. Do you have anything to ask? Why are you here? Why are you here?
Well, this has become an annual tradition for me. I have epilepsy. I'm still a minor. I'm 15 years old. But I've been coming since 2016 with my family. So.
And where is your family now?
Right now, my family's off enjoying Disneyland.
Oh. And have you found it helpful here?
Yeah. It's nice having this community, being able to have these opportunities to learn, and to just be with the community.
And it tells you that you're human, right?
Yeah.
Did you always know that you were human?
In a way. Like, I was diagnosed with epilepsy when I was 5, but I think I've had it from younger. But I've had 2 brain surgeries in my life, one when I was 5 and one when I was 9. But I've been seizure-free for 5 years now.
Applause! Applause! Applause!
And the only medication I'm on is the ketogenic diet.
Nice.
It's been working amazingly, and I've had a great quality of life, and I've been approved for driving.
Oh, nice.
So if you're going to say something to people, what's the message you would like to give them?
Don't feel scared of life with epilepsy. I've gotten very easily 5 years seizure-free now, so I don't really have the best experience to tell you about being in the deep pits, but I've had a little bit of experience being in the deep pit.
You were in the deep pits. You had 2 surgeries. You think that was easy? I never had a surgery in my head.
When I was too young to fully process it at the time. But yeah, it was scary, but I'm on the other end now, and I'm still enjoying life and still doing things.
And what advice would you give to somebody who has epilepsy? Because they're going to look at you and say,
just continue to live your life. What you loved doing before, see if you can still do it now, or find another avenue for what you can do so that you can still enjoy your life and not let the fact that you have epilepsy keep you down.
you shouldn't. You shouldn't. As we said, there are many, many causes of epilepsy. And some people have epilepsy because the brain doesn't function very well in more than one domains. And some other people have epilepsy with the brain functioning perfectly fine. We cannot throw them all in the same area. We have to try to adjust it, figure out how we're going to help each one, each person. And you know, a story like yours is wonderful because it tells us that we're doing something. We're doing something and we're helping. So thank you very much, and maybe I'll see you again next year. And if I see you next year, you will tell me more. You can be up here working with me. Right? How about you guys?
Well, I have had epilepsy since I was a baby, and I still have it to right now. I'm 18 years old. I'm gonna have the VNS implant, so that I'm looking forward to that. It's on Thanksgiving weekend, so the best weekend to have it. I've been on, I want to say 5 to 6 different medications, so those haven't helped. I went on my 3rd opinion to a new doctor, and she's the one who gave me like the clear to have the surgery. There's multiple things that I can do. I compete in pageants since I was 5. I'm all over the community. I'm well known as Miss San Antonio, Miss Texas. So everywhere I've been known, and even having epilepsy, that hasn't stopped me from, competing, being out of my community. Yeah, I'm at home. I do school at home because I got bullied for what I have, but to me, I really don't care about what people have to tell me because, it's my life, nobody else's life, nobody else has to deal with it. The only person who has to deal with it is me and, my family that deals with me 24/7.
And how often do you have seizures?
Every day.
Every day.
Okay. And did they tell you what syndrome you have?
I have focal and tectonic seizures.
Okay. Did they tell you where they come from?
One comes from the core of your brain, and the other one comes from your temple. From my temple.
Okay. We have some people who are doctors from other institutions, right? What do you do?
I work with Children's Hospital.
And what do you do?
I work with division of neurology. I'm more on the administrative side.
Administrative, so you cannot give us a medical opinion.
I'm sorry.
Do you have anybody who can give a medical opinion besides me? No? Gee. Was epilepsy surgery considered?
Yes, that's why I'm going to do the VNS implant.
Has epilepsy surgery considered to take out part of the brain where the seizures come from?
No.
Why not?
They haven't really recommended that to me, because the only first thing that they recommended was like doing the VNS, and then if that...
Just make sure that you say you met a crazy nut from the Bronx who said, let's evaluate for the possibility, I don't know much more, but what you said to me, they think that they're coming from the temporal lobe. And if they come from the temporal lobe, there is a possibility that if you do surgery from the temporal lobe, you can do very well. There is a lot of testing that needs to be done. But if it only comes from one area of the brain, then surgery may be beneficial. So please go to, there was a talk next door that talks about the National Epilepsy Centers. That's one of the things that we're trying to advocate to people. And I'm not saying that surgery is good for everyone, but it's something that you need to consider. It helped her. Okay? And when you hear about epilepsy surgery, you go, but it ain't. If you do it very, very carefully, and you are in good hands, then, and if they understand where the seizures are coming from, that can help you tremendously. I do not know in San Antonio if there is there an epilepsy surgery program?
I'm going to one in Austin. I'm doing the one in Austin.
From San Antonio to Austin? Do you walk there?
No.
It's an hour ride.
That's all?
An hour ride.
An hour away, that's all?
Yeah, they drive.
By car is only 1 hour. Isn't San Antonio in the south?
Yeah, sometimes so.
And Texas?
In Texas.
I mean, in Austin is further up.
Yes.
It's only 1 hour.
Yes.
Wow, you must drive fast.
It's dependent on the...
So the doctors at Austin, they told you that surgery is not an option?
I've had doctors here in San Antonio that told me that surgery wasn't my option. And I asked them when I was 10. And to right now...
10 years ago, 8 years ago, it would be a different story.
Yeah, 10 years ago.
It would be a different story. I think Dr. Laviner is...
Yes, that's my doctor. That's for Dr. now.
No, I'll talk, find out.
Yeah, that's find out.
Okay. All right, I'll ask him. All right. Anybody else has any other questions that they would like to ask?
I have, how do you know you're the right candidate for epilepsy?
That's a great question. And what it is first of all, you have to have seizures that one and sometimes two medications don't control it. Second, but even that, usually you try at least one medication. Then the seizures should be coming from one part of the brain. And that part of the brain, if you take it out, you do not cause any major problem. And there's some areas that it's much easier to take out than others. The temporal lobe is one of those areas. And you just want to make sure that if you take it out, the person can talk and think, etc. And there's been a lot of progress in doing epilepsy surgery. So that's something that we'll consider very quickly in a lot of institutions. But there's a discussion among people is that the idea of epilepsy, and I work in the Bronx, people don't feel comfortable with the idea that epilepsy surgery, in your case, I don't think it's an option. I like to know the EEG, but usually, unless they know that it comes from a particular area of the brain, it doesn't work. There are some other surgeries that are available, and if you go around, and I'm not advertising any drug companies, I'm not advertising any epilepsy centers, all right, except my own, and you're not going to come to the Bronx tomorrow. But there is a company here that's called Neuropace, and there they do a form of treatment where they put an electrode in the brain, and the electrode senses that the seizure may come, and it gives a buzz to try to control it. And it seems to work in some of the patients that they cannot have other types of surgery to take it away. The VNS is another possibility that they've been doing. There's something also that's called deep brain stimulation. And again, people are working to figure out what's the best way of approaching a difficult problem. And there are two kinds of seizures. Okay? One is the seizure that starts from one area of the brain, and that's called a focal seizure. And the other is a seizure that starts from both sides of the brain at the same time, or at least involves both sides. Not every part of the brain, but both sides. If it affects both sides, you cannot do surgery to take it out. You may be able to modulate it by deep brain stimulation. If it starts from one area, well, you may be able to take it out. Now, one of the other things that happens with the seizure is it starts in one part of the brain, and then it may progress to affect other parts of the body. That second part is not important. The important part is the first part, where the seizure starts from.
So if it's already like how I have two different types of seizures. Like I have tonic-clonic seizures and I have focal seizures. So it's already...
No. It depends on what exactly your brain waves and your MRI show. As I said, there are many different etiologies. But if the seizures consistently come from one area of the brain, the fact that you can have generalized tonic-clonic seizures is less important, because if you control the focal seizures with surgery or medication, the others are going to stop. But sometimes, some people have syndromes, and that's what I keep on telling you, that I need to know what is the syndrome, which is, who are you? Who are you? Everybody's a little bit different. The syndrome will tell me perhaps what the prognosis will be. Okay? So there are some people who have both focal and generalized seizures, and they don't start from one part of the brain, but more than one part of the brain, and it's difficult to take it out. But with all your successes in life that you have, speak seriously with Dr. Lavina and find out if there is a possibility of epilepsy surgery. She's a very good doctor, so you know. And if she says there isn't, that's fine. But if somebody told you you could have surgery and you start wetting your pants, don't. Okay? Don't, because nobody's going to hurt you, but it may help you and it make your life hopefully much better, right? She agreed. Okay? Any other person who would like? From the administrative point of view,
No.
don't scare me.
Uh,
I cannot tell you what my RVUs are.
I have generalized. And I guess when I got diagnosed, I was 15 and surgery was off the plate. But basically back then, it wasn't one of the things you ran to. So I've been on it now for 15 years. Momento SR. I guess my fear always is, will I ever have to force to because it will just not. So will I ever need to switch that medication to something else? I mean, when I follow the rules.
If you're controlled, why do we like to change it?
I don't want to, but I'm also curious if that grandma does come through, okay, then it just continues to come through.
But you don't have them now.
But again, it depends on the sleep deprivation, that depends on the sleep.
Yeah, so the whole idea is that I do not know how frequently you had seizures before you started the medication. And some people have seizures in very prolonged, after prolonged periods of time. What happens is, if we go for a long time and we feel fine, we forget that we may not take the medicine, and we may not sleep regularly, and we may have an extra piece of alcohol, but or whatever. But one of the things that we're trying to find out in medicine, and it's not easy because it requires a lot of money, is if we can prognosticate why seizures will come. And there are systems that they try to relate stress by questionnaires, etc., to see if you can identify what are the triggers that the seizures that you may have. I don't. You are in California, so I do not know. The colleagues that look a lot about of stress and epilepsy is one of my colleagues, Dr. Hout in the Bronx, and Dr. Privitera in Cincinnati. So you may want to look. No, you want to look in the internet and find out about the stress and epilepsy trials that they're trying to figure out if you can use the diaries that they suggest to figure out what will happen. But if the seizures are controlled, I will not change the medications. Switch it for what? Oh, if you have more seizures? Yes, sure. Sure. And there are new medications that can come and play a role at that time, either because they were invented or because you could not use it because of your sex and age. For example, which we used a lot for people, but now we're afraid to use it for women of childbearing years. But I would. And also another thing happens in epilepsy is that seizures may stop. And we don't know when they're going to stop. There is a syndrome that's called juvenile myoclonic epilepsy. And that syndrome was discovered by a German professor named Jans. And what he described is that the people wake up in the morning and they drop the soap when they take a shower, or they start shaking, and they have it for a long time, and they don't complain because they can go along with their lives. And then eventually they have a generalized tonic-clonic seizure, and somebody brings them to their attention. When it was first described one of the most famous doctors, epileptologists, epilepsy doctors in the world, looked at Jans and he said to him, "You are full of shit." That syndrome does not exist. Now, I met Jans when he was 85 years old, and he was still shaking from that experience. One of the things that's important to know is that we don't know everything. That condition, the juvenile myoclonic epilepsy, responds explicitly well to valproate. In fact, that's the first indication ever to be given to that medication. But now we cannot get it. In Europe, they have outlawed it, unless there is no. So, but if you're beyond the childbearing years and you're not planning to have any kids and you want to try that medication, it may work. Okay. The other thing is always reinvestigate what caused the epilepsy, because new things come out. Imaging has improved tremendously. Genetic testing also has improved tremendously. And you need to know the genetic background upon which a condition occurs. And new treatments may become available if we understand that. We don't have the full set of the information. Okay?
I just have a question about the juvenile.
I have a lot of answers.
So I was just wondering, what is kind of like the age cutoff for this diagnosis, or like when is it most likely to evolve into other diagnoses?
So it's called juvenile myoclonic epilepsy because it was studied by adult epileptologists. So anybody who's in adolescence was called juvenile. So usually it starts in the peri-adolescent periods. When Jans was doing his work, adolescence used to be about 15 or 16. Now adolescence is about 8 or 9. And a lot of this has to do with the diet probably that we have. So it starts much earlier. But it seems to have a hormonal influence that has not been proven, but usually the onset is about the time that you hit adolescence. And the majority of the seizures is myoclonic seizures. The generalized tonic-clonic seizures that may bring you to the attention of the doctor actually are easily controlled. And there is a medication that Sunita may remember. It's called primidone. And primidone is a derivative of phenobarbital, and it works like a dream in patients who have juvenile myoclonic epilepsy to control the generalized tonic-clonic seizures, but it doesn't control the jerks. When Jans described the syndrome, and it's written many, many times, and that's the other thing that's fun about having experience of a lifetime, is that we thought that it never goes away. And we kept on repeating, it never goes away, it never goes away. And the last time I met Jans, he said, you know, my patients are now in the 60s. They stop. So sometimes later on, some of the seizures stop, and we don't know when. We learn from all of you. We learn so we can apply the knowledge that you gave me to somebody else. What you shared with me, the same thing, and your feelings and the fighting that you showed us. That's what makes us go. Otherwise we wouldn't be able to continue. Any other questions?
I'm used to the statistic of 1 in 26 will have epilepsy in their lifetimes, but I've heard that that statistic has changed. What's the current statistic?
It depends on why you're going to use the statistics.
Well, I've just seen it on a lot of promotional material, like
All right.
come to this.
So we're dealing with the problem that epilepsy is a disease of the young people, and it's also a disease of not very rich people. That's a problem because you cannot generate enough interest in Congress so they can help us do more research and identify new treatments and better understand what the epilepsies are all about. So you have two groups of people with epilepsy. One is a person who has seizures and they are absolutely fine in what they do. And you have those people with epilepsy that have a lot of other problems, intellectual disabilities, etc., and their life is totally destroyed. If we go to the Congress and we say, help us cure epilepsy, because we have normal people who have seizures, you know what we're going to get? Nothing. If we say, help us because epilepsy is a deadly disease, you know what we get? A little bit more. Not enough. A little bit more, because this is not the disease that the senators have. And if they have it, they say, oh, no, I just froze. So they don't want to give that much money for research in epilepsy. So one of the things that we came by, because it's a tremendous need to do more research, to try to understand all the different facets of epilepsy. So we came up with the statistics. 1 in 26 people may have experienced a seizure sometimes in their lifetime. But that's important in terms of PR, to get more monies to do the research. And some seizures will go away, and we call those self-limited seizures. But some seizures may continue, and you can have a perfect, good life, and sometimes it can be difficult. And it always bothers me, and I make that example all the time. If you have a migraine, do any of you have migraines? Kind of. What does the migraine start with? Pain. The first thing you have is pain. I don't know what that kind of migraine. Any other migraine? Huh? Something that changes, you know. Dr. Dergalas says an aura, which is the beginning of something changing. So you may see flashing lights, okay? Or you may have some zigzag patterns or some numbness. And then the headache starts. And you go, oi, 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 and you stay there, oi, oi, oi. Does anybody bother you? No. They say, oh, you have migraine. Sit, be quiet. If you have the same thing and then you have a generalized tonic-clonic seizure, you know what's going to happen? Get out of here. I don't want to see you. You're scared. And what's the difference? The perception of the body. And that's the problem that we have with epilepsy. That we tend to think that it is a disease that can, it's a cursed disease, and it's not. It's a disease like anything else that has many, 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 many causes and many treatments. And we need to figure out what is the best treatment for the person. And more important is, besides having seizures, there is the rest of their life. And how are they doing in the rest of their lives? And that's what we have to work with. Any other questions? How about from back there? Any questions? Why are you here?
So my 7-year-old has epilepsy.
Okay.
She's my mom.
Are you a 7-year-old?
No, she's my support person.
Okay. So what made you come here?
To this particular session or the
Well,
this event in general?
I would not be presumptuous to say that the only reason we came to Disneyland is to come to this particular session. Although I would have thought that it's the only reason to come to this.
Was one of the main reasons. Yep.
So tell us why you're here.
So my 7-year-old has epilepsy, and she was diagnosed officially about a year and a half ago, and it's all very new to us still. We're still trying to figure out the different types of epilepsy, what her type of epilepsy means, and just resources and community and any bits of information, because it's all new.
Year and a half, and it's a lot of pain and fear that it goes. How long do the seizures last?
So she has two different types of seizures with me. So she has her absent seizures, which last maybe 2 to 4 seconds. And she also has atonic seizures, which are like the drop seizures. She has those maybe 2 times a week. And sometimes it can be a very quick recovery period, and then there's times where it'll make her tired and lethargic all day long. So sometimes we kind of just take it day by day.
And those are very scary when she falls down.
Oh yeah, and that's what actually had led to our initial diagnosis of her epilepsy.
And did they give a name to the epilepsy that she has?
No, just the types of seizures specifically.
And you were not here from the beginning, but you guys who were here, do I buy, just give me the name of the seizures and I know what kind of epilepsy you have? Nope. I need a lot more information. I need what, first of all, I know if they are, how they're doing in the everyday life, how they were developing before that. I would like to know what the EEG is, and more importantly, I would like to know the genetics that may play a role. Have you had genetic testing?
We have. Nothing was found for the genetic testing. But part of my daughter's care plan is that they want to do genetic testing every 6 months for the next 2 years to see if they're able to pick up on any additional variants. Because as of right now,
Who pays for that?
it's part of our insurance.
That's a very good insurance. What's the name of that insurance? You should all get that insurance.
We've had a pretty good care team, but like one of the things that we found specifically is that I have to do a lot of research on my end and just getting familiarized with certain terms or what other people are doing as part of their care plan is to be able to bring it back to the care team and say, hey, I've heard that this is a possibility.
Give me a suggestion.
So one of the things that we were kind of tackling with was she wasn't responding to medication, and the initial Keppra initially. So that was kind of their like, okay, here's our gateway, this is what we're going to start with. Everything was very weight-based, and we're like, okay, well, we've gone up on this medication, genetics didn't find anything initially, she's still having regular seizures, now we're noticing these absent seizures, like, there has to be something that we can either incorporate on top of the Keppra, sub it out, or is there some kind of additional treatment that we're able to add? Because she's also developmentally delayed and nonverbal. So we're like, there's very little feedback we're able to get. So we found CBD oil was like something that a couple people had recommended to me. And just based on support groups and mommy Facebook groups type of thing, was able to come across Charlotte's Web. I don't remember what it was called, but there was an additional website that we had found recommended pediatric dosages for CBD oils in conjunction with the regular epilepsy medication. So I was able to take all of these informations, all of the brands, all of the websites, and take it back to her neurologist and say, here's all this info. I don't have the specifics on all of this, but like, what can you tell me as an official, like, yes, this might help, or yes, let's go ahead and try this. And even still, she's still having seizures on a regular basis, and anytime we do have to up her medication, whether it be because of illness, breakthrough seizures, whatever the case, it's a lot of like, okay, I've done additional research, this is still happening, what can you say is like part of her care plan now? And then additionally, like having a seizure service animals kind of within our scope of the next, phase of her care. But all of these things we weren't informed about. There's a lot of things that I've had to just kind of look up and get recommendations from other like parents and families, and just bring it back to the table and say, hey. For in our case, yeah. I wish I worked on my husband. In my daughter's case, see, good to know. In my daughter's case, a lot of times her drop seizures happen when it's related to a sleep event. So whether she's waking up from sleep or right before she goes to sleep, she starts to have like her auras or just gets really unstable. We call it the 1,000-yard stare. And she starts to get really kind of off balance, and we're like, okay, we know that a drop seizure is coming. So and she's getting bigger. Like, she's only 7, don't get me wrong, but as time goes on, when you're trying to catch the dead weight of a child having a seizure that's about to hit the floor, there's only like so much reaction time that you have. So one of my hopes for getting a service animal for her is to be able to, in the events of a drop seizure, be able to provide some kind of level of support, or, you know, whether, I forgot what the term was that we learned today, like pressure therapy for afterwards when she's coming out of it, but just having that additional pair of paws, in this case, to be able to help kind of support that, because, you know, it's harder as she gets older. Like when she was a toddler and we were kind of dealing with this, it's a little bit easier, but in the sense of, like, it's a very isolating experience when you're the only person that has to have eyes on your child at all times, because it's not like an alarm goes off when these events happen. So being able to have that level of support of like, okay, if I don't have eyes on you at all times, I at least have a little bit of reassurance that you're not going to fully hit the floor. Or, you know, if I'm in the kitchen or you're in the shower, I have a little bit of additional support in that moment. So hoping that a service animal will help at least provide kind of another layer up for us.
It's very important to see what people think and what support that you get. One of the biggest problems that at least I have in the Bronx, my insurances are never going to cover any animals to come. And that's why we need to make sure that we have a lot of changes. As I was saying, the public face of epilepsy need to change, because we need to provide comprehensive care that goes beyond giving a medication. And the service dogs can be very helpful. Again, in your daughter's case, understanding why she has it and how you can prevent some of the drop seizures. There may be some options that you may need to discuss with your doctor, but it's very important to understand what the genetics are. Yeah. And you raised the point that you try medications that may work for one person and may not work for another person. And the system is such that you can do that. As I said before, if you like to cook and you like to use different ingredients, but if you cannot afford to buy them, I'm sorry. And it's not you. It's your insurances that they will not use that. Often they would like to use you. When we call, we want to, in case I'm a child neurologist, I want to use a new medication. They say, have you used X, Y, and Z? And who's the person on the other side of the phone? An 18-year-old who was given a script. Give me a break. All right, anybody else has any other questions? No? Nothing? I mean, I'm going to be safe? Well, I managed to spend 55 minutes talking. So what did you learn? That's my favorite question when I teach my residents. After we finish teaching, or my teaching, I said, what did you learn?
It is nice to hear people that have the same problem or the same experience they have. And it makes you feel good.
Okay, what else? That nothing is perfect, that we're trying the best we can. We need to change the awareness of the people who make the public policy decisions, that one medication may not work, but you have to, and also, we now discuss the most important thing in medicine at this point, that it's not run by doctors, but it's run by administrators. So I have, the people I work with, not me, have 15 minutes to see a patient for a follow-up visit. 15 minutes to do what? And they have to fill out forms and forms and forms. And what am I going to do in these 15 minutes? So that doesn't work. And you know what? If I see you the first time, I'll give you my deadly secret. The first visit is an hour long. Oh yeah, that's great. And I have no idea what's going on. That's not rare, because I always have a wonderful idea. I'm an amazing doctor. But you know, I have no idea what's happening. I said, okay, let's do a test. So now it takes 2 or 3 months to get the test, you come back. Now I have to make a decision in 15 minutes. Ain't working. And you know, do you think I'm going to ask you if you're happy at your work? No. But is that important? Yes. How is your condition affect your work or your school, etc.? And I don't have time. Anyway, I'll be here next year, so hope to see you. And thank you very much for coming.